Once again, good evening and a very warm welcome to the webinar this evening, which will be on urinary incontinence and pelvic organ prolapse. My name's Jan. I'm the clinical nurse specialist in Continence Care here at Benenden, and I'm joined today by the expert speaker, Mr. Abhishek Gupta, consultant urogynaecologist. Tonight's session will begin with a presentation from Mr. Gupta and myself, followed by a live question and answer session. If you have any questions at any point, please feel free to submit them using the Q&A icon, which you'll find at the bottom of your screen. You're welcome to ask these anonymously or include your name. Just a reminder that this session is being recorded, so any names shared may be visible in the recording. And to help us get through as many questions as possible at the end, please keep your questions brief. If you're interested in booking a consultation, we'll share relevant details at the end of the session. And I'd now like to hand over to Mr. Gupta.
Good evening, everyone. So my name is Abhishek Gupta. I'm a consultant gynecologist and a urogynecologist. I trained in London and Southeast, and I completed my specialist training in 2012. And then I joined Dartford and Gravesham NHS Trust in 2012 as a gynecologist. Obviously, I am a urogynecologist and I also do minimal access surgery. And from last year, I have started doing robotic surgeries as well. So I'm a robotically trained surgeon. I did my training in this region, as I said, and I've done my advanced training in urogynecology as well as laparoscopy open surgery. And obviously, I am a member of British Society of Urogynecologists and Royal College of Obstetrics and Gynecology. And from last year, I'm also a member of British-Irish Robotic Gynecology Surgery, BROGS as well. So that's me. And I have been working in Benenden Hospital since 2012, end of 2012. So I've been here for the last 12 years as a consultant. Now I'd like Jan to introduce herself.
Thank you, Abby. So I'm Jan. I'm the clinical nurse specialist in Continence Care here at Benenden. I've got probably over 20 years experience now in urogynecology nursing, and I manage the specialist nurse team here at Benenden. And we're very lucky we have 4 clinical nurse specialists that can all help to manage your symptoms. We run nurse-led clinics, and we also offer urodynamics, which is a diagnostic test. And along with Mr. Gupta, we run multidisciplinary team meetings to discuss your symptoms, your case, to make sure we're giving you the right treatment at the right time.
Thanks, so what our webinar is to give you an overview of what incontinence prolapse is about, where you can seek the help, what are the common things we do, how do we provide help for you, and what you can do to help yourself as well. And so we basically want to give you as much knowledge as possible to empower you to seek help, or even to know your own body and see whether what's, and that will empower you to know what's going on and seek help or help self-benefit as well with self-help strategies. So we'll give an overview of what urogynecology is, what overactive bladder means, what stress incontinence means. Jan will talk about nurse assessment because it's so important to work in a team, especially for urogynecology, because surgery is not the only option you have. It's lots before and after surgery. I'm sure everyone has learned about the issues meshes went through and the negative publicity the meshes got for incontinence. And then they were stopped in 2018-19 time. And it was not the tape which caused problem, which is for incontinence, is the way the tape was implemented, and unregulated putting the tape was a problem, because half of the patient may not needed a tape. They needed a multidisciplinary team to work with them to get them better. So it is so important, and it's a recognition everywhere that urogynecology is a team-based approach where specialist nurses, specialist physiotherapists, and a specialist consultants, they work together to bring the best outcome a woman deserves for incontinence prolapse, because it's quite personal to you. It does affect people's confidence in more than one way, And there is a need for a multidisciplinary way of working to make it happen and make it better. Then we'll talk about prolapses, and then I'll also tell you about various resources you can look yourself, because when you put on Google and all that, you get a lot of unregulated media proven things as well, which we don't know whether they're valid or not, whether they're logical or not. But I'll give you some resources which we recommend you can go down and tap to endeavor to help you to have a bit more knowledge and evidence-based knowledge. And then we'll try to answer as many questions as possible in the short time we have today. So what is urogynecology? So it's a subspecialty of urogynecology, which helps with basically female pelvic floor dysfunctions. And it can range from anything which causes urinary incontinence or symptoms of urinary incontinence, vaginal prolapses. Recurrent UTIs can be from a mixed bunch of falls between sometimes urology and urogynecology, because it can be related to upper tract as well, like kidneys and ureters. But lower tract, which is bladder and the vaginal issues, then recurrent UTIs also comes under us. Bladder pain syndrome, and obviously pelvic floor injuries post-childbirth, because a lot of trauma has happened when you have a vaginal delivery, or especially when you have a prolonged labor or instrumental delivery like forceps or venous delivery. So trauma has happened. So these are main areas where we come in, where specialization, where we can help. And that's what urogynecology encompasses. So what are the common referrals we see in our area? So as you can imagine, we see a lot of problems with bladder problems, which can range from people requiring frequency, urgency waterworks. They need to go often. Their frequency, this affects their quality of life, and they may leak, which may be involuntary. We'll talk in a minute what all that means. Obviously the prolapse, which can have symptoms as well, and recurrent UTI, bladder pain, and as we said, pelvic floor injuries after childbirth. So let's start talking about the issues for first range of referrals, where the bladder referrals, which are quite common to us, where we get patients referred for urgency, frequency, have to rush for waterworks, or you leak, or you might have to wear a pad. So often the incontinence can be either urge incontinence, which is with urgency, stress incontinence, which is unprovoked with no urgency, but you're doing an activity, which is like coughing, sneezing, lifting weights, jogging, sexual intercourse, and sneezing. So anything which increases your tummy pressure or a jerky movement, that leaks, that's stress incontinence. However, a lot of incontinence are mixed picture. So sometimes you can have urgency waterworks and stress incontinence both. And patients who have pure stress incontinence without no overactivity of the bladder, they may also present with overactive bladder. So it's so important for us to understand, because when patients are leaking involuntary, nobody wants to leak in front of strangers or any places, because that's embarrassing. So what our natural reaction is to help ourselves to keep our bladder empty. So we train our minds to keep going for toilet, to keep our bladder empty all the time. And then we think that we are visiting often, but it's actually our nature, because we don't want to be leaking. And that may be stress incontinence. So sometimes that's where Jan and her team are very good in finding out from your bladder diaries and everything else, whether you have only a component of stress incontinence, mixed picture, or you got urgency. So I'll talk one by one and hope it will be helpful. So what is an overactive bladder? So overactive bladder is a bladder which is not in your control, so it's involuntary. So bladder is, if you imagine my fist as my hand as a balloon, and it's full of water, that's your bladder. So in a normal circumstances, when you have a bladder around 300, 350 mL of fluid in the bladder, you want to go for a wee. You usually find you can hold it. You find when you find the toilet where you go in, relax, and then you tell your mind, now I'm in a safe place when I have to start emptying my bladder. So the bladder then contracts, and that happens when you relax yourself and give that signal to your mind that now I can start weeing, and then the bladder contracts and then you wee. However, with patients with overactive bladder, your bladder is constantly doing this. So this balloon is not in your control. The balloon is getting this contraction, and that's called detrusor contraction. Hence, you keep going this urgency and frequency. So you want to go for water work often. And after the patients who have really an overactive bladder, which is contracting like that, you will have peculiarly small amount of urine you pass and often. So the problem is you're not able to hold the urine well too much. And when bladder sometimes then becomes like this, the contraction become more powerful, then you start leaking. So that is an overactive bladder. And as I said, the symptoms are urgency, which is you need to go. And often you will have some kind of symptoms like when you're putting your hand for washing. So you touch water or sound of water may make you go and rush. Often what we call is a lock and key, that you reach home, you want to go for waterworks, you're rushing, you put the key in on the lock and you start leaking. So these are kind of cues for us that the bladder can be overactive. And obviously sometimes you have to get up in the night for overactive bladder. However, sometimes the nighttime getting up can be normal, because after a certain age, the physiology of the bladder does make you get up a couple of times in the night. So this are kind of overactivity bladder that can happen, as I was describing about the age, but sometimes it can be nerve related as well. And you can find a terrible overactivity of bladder with patients who have got MS, for example. But overactivity can happen on its own without any cause.
So looking at managing overactive bladder, particularly if you come to the specialist nurses and we're treating you, as your first appointment, Mr. Gupta mentioned about filling in a bladder diary, and that's really important. You'll measure your intake and your output for 3 days, and you'll measure how often you pass urine, and what, more importantly, I think, what the voided volumes are, how much you're passing, so we can see, are you going very frequently with small amounts? Can your bladder hold on? But if you're treating overactive bladder, we always look at your drinking. Keep your drinking between 1.5 and 2 litres. That's all you need to be drinking in a day. Look at how much caffeine you're having. So caffeine's a bit of a diuretic, so it will make your kidneys make more urine, but it's quite irritant to this bladder. It will set this sort of twitchy bladder off and give you more urgency and frequency. We would normally say 2 caffeine drinks in a day would be fine. Otherwise, look at decaffeinated, look at fruit herbal teas, look at other substitutes. We'll work with you on a program of bladder retraining. So if you're emptying your bladder every hour, we'll try and get you to stretch that 1.25 hours or 1.5 hours, because you should be emptying your bladder, around about that 3 hours if you haven't got bladder symptoms. Pelvic floor muscle exercises, I'll talk about those again a little bit later on, but they're key. And often a strong squeeze of that pelvic floor muscle can help you when you have that awful urgency to just momentarily calm that bladder down. And that might be the difference between getting from where you are to the toilet without having a leak. If you have bothersome nighttime symptoms, we'd say have your last drink a good sort of 2 hours before bed, so around 8 o'clock if you go to bed around 10, and try and make that not a caffeinated drink. Have decaf, have a milky drink, Horlicks, Ovaltine. Avoid the hot chocolates again, because you're going to have caffeine in that. If we know that you're maybe not emptying your bladder completely efficiently, sometimes we get you to double void before you go to bed, and that's just around emptying your bladder as normal, cleaning your teeth, getting ready for bed, emptying again 15 minutes later before you go to bed, and that can sometimes help with the nighttime symptoms. We're going to look at what's going on with your bowels. If you suffer with constipation, a full bowel is going to put pressure onto your bladder. So do we need to, advise any medication, help you with that? And then again, we'll review medications that you're taking. Are you on some blood pressure tablets, some diuretic that's actually giving some of these symptoms? And then obviously we'd then discuss that with Mr. Gupta and maybe advise to GP to review some medication.
While we're on the subject of medication, you might be in, especially when you're getting up in the night, often it's worth checking with your GP what medications you are on. Very often, because it's a very common medication, people are on called nifedipine or amlodipine, amlodipine or calcium channel blockers, and they can make you go up. These are mainly hypertensive medications, but they have increased risk of you getting up in the night few times. So the normal bladder is fine, but if you're on medication which will make you get up in the night, then you might like to review these medications. So now with what we call as fluid management, training yourself, pelvic floor exercises, if your symptoms are still ongoing, then that's the time when we start thinking about putting the medications on. So there are two kind of oral medications which we can try before we do anything invasive. So one is called anticholinergic, and we just put the names of the medication which are there: oxybutynin, sulfenazine, tolterodine. They're different kind of anticholinergics. So what anticholinergics does, it prevents the contraction. That's the method of working. It prevents the contraction. Now they work on the same receptor as you have for your salivary glands, you have for your gut. So sometimes they have side effects which are like constipation. You can have a lot of dry mouth. They're not good medication if you've got glaucoma. But if you can tolerate the side effects, then the normal effect of whether it's helping or not comes in place. So it takes 3 to 4 weeks to start showing the effect. Betmega, which is mirabagrone, is a slightly different drug. It works on a slightly different receptor. So anticholinergic prevents the contraction. Mirabagrone helps to relax the bladder. So they work in a slightly different receptors. Mirabagrone has got lesser side effects than anticholinergics. It doesn't give you that constipation, dry mouth kind of side effects. It's only thing which we need to be careful if you've got uncontrolled hypertension. So you've got uncontrolled hypertension, or you've got cardiac rhythm problem, then we have to be kind of careful with Betmega. Otherwise, it's safer, especially for elderly population. It's got long use of anticholinergics are associated with dementia. However, Betmega doesn't have that problem. Then if this doesn't work, then we do a specialized test called a urodynamic test, which we try to do it. It not necessarily has to be, but we try to do it to establish the treatment, to establish the diagnosis, to make sure we have not got it wrong. And Jan will talk about urodynamics in a minute. And then we're going on to slightly invasive treatment for overactive bladder. One is PTNS, which is percutaneous tibial nerve stimulation, and now recently, which we haven't evaluated, but there is a company which is coming with transcutaneous nerve stimulation, which is easier probably for patients to use. And that what it does is it stimulates the nerve, and it helps to relax your bladder to reduce the contraction of them. And then so the PTNS is usually offered by Jan and her team privately. Botox is medical treatment where what we do is we have a look inside the bladder with the camera, and we inject around we start with 100 international unit of Botox on the bladder. For overactive bladder, where patients' quality of life is really affected, Botox works really well. Patients do within 2 or 3 weeks, patients' quality of life are much better. They're not going for that often. They're not having a lot of urgency. The only two flip side of Botox is, one, it keeps needing to be repeated. So every 6 months to a year, it will need to be repeated. And the second is sometimes the bladder does become so relaxed, because the whole idea of Botox is to slightly paralyze the bladder and relax it, that you're not able to empty the bladder well. And hence, Jan's team teaches all the patients who want to have the Botox how to catheterize themselves. It does sound more horrible than what it is. Once you've been taught and empowered, it's not actually that bad. And it only 1 in 12 women who are requiring Botox will require the intermittent self-catheterization. So 11 out of 12 times, you won't need it, but we'll teach you before we do the Botox. And then the last option is sectoral neuromodulation, where they put a little electrode on the back with a transducer, and that creates a reflex to stop your bladder contracting, overactive bladder contracting. Unfortunately, sectoral neuromodulation is only done in sub-tertiary centers, and the only one I know which is functioning at the moment where it's been done is in London. So we don't have any local centers where the sacral neuromodulation is actually offered, which I know of. So let's talk about the other component, which I was talking about, stress incontinence. So all incontinence has to be involuntary, because if you're voluntarily leaking, then it's your weeing, not leaking. So stress incontinence is involuntary. So what happens is when you cough, sneeze, now my hand, again, I'm showing you this hand. So if that's a balloon, your balloon is stable, but there's a tube which drains water out, which is called urethra. So when you cough, sneeze, lift weight, a lot of pressure goes on the tummy, which is trying to press on your balloon like this, which is, and as long as you got a good support just below your urethra, then you will not leak. But if you have weakness in that area, then the urethra, which is a tube you can see there, doesn't close very well. And then there is still space left for it to start leaking. Now, various risk factors, and that's all part of the pelvic floor. One risk factor is vaginal deliveries, especially if you have instrumental deliveries, and that causes weakness of that area. Menopause, so woman body goes through a lot of trauma, and menopause is one of it. And menopause does cause weakness of the tissues there. If you are overweight, it's so important for weight to be addressed first. Smoking, chronic cough really doesn't help, because it will make your pelvic floor really weak. And even if you want to do any operations or any surgery to help, you don't heal that very well. And some neurological disorder and the can cause that as well. So what are the treatment of stress incontinence? First is the lifestyle treatment, which is the structured pelvic floor exercises, where Jan and her team comes in. So you need to see specialist nurse or specialist physiotherapist, do pelvic floor exercises. If you're overweight, lose weight. And then if that doesn't help, then we can go a step further. And there are 3 recognized treatments. So after the mesh has been stopped, there are 3 recognized treatments which we can offer. And we offer all 3 at Bennington Hospital. One is urethral bulking agent, which is called Bulkamid. It's a local anesthetic procedure. It's done in outpatient. It's done in local anesthetic. It's a use of a permanent gel. It works in around 55 to 60% of the patients, and it's all about quality of life. So it's not about you leaking or not leaking. Is this affecting your quality of life? So if your quality of life is affected, and everybody's quality of life is very different. Some people quality of life, when you've got young children, you're going for trampoline with your children or go running with your children and you leak. That's your quality of life. Other people, somebody want to play tennis and they're leaking that during playing tennis. That's their quality of life. So what affects your quality of life? So therefore, success of our operations, we deem as how well it has improved your quality of life. So when we do Bulkamid, which is a small injectable procedure, which works around 55 to 60% of the patients. It's local anesthetic. It's a permanent gel. We haven't seen any long-term issues with Bulkamid. There's a small risk of bleeding infection, risk of a temporary catheter, and if you end up with a catheter, it's usually a few days. But we haven't seen any. Either it works or doesn't work. Sometimes we have to give a top-up, and I'll explain you in the next slide, because we've got a little slide for Bulkamid to say where it goes and why it needs a top-up. And the next 2 surgeries are quite a major surgeries. One is called autologous fascial sling, and another is called corpus suspension. The both surgery are major surgeries, and the whole idea of doing this surgery is to give a support at the neck of the bladder level, which is your urethra. So through the vagina, that's a support we want to give. So when the bladder pressure increases, your urethra is well supported and you don't leak. So these are 2 major surgeries. The success rate around 80%. So unfortunately, none of them are 100% successful, but they're around 80% success. And when we look at our data or our results, we do get more than 180% success rates with our surgeries. But they're major surgeries, and they require 6 to 8 weeks recovery period. They do require quite a bit of an engagement from us and you to make sure that you understand the procedure, you're ready for the procedure, and any issues post-operatively we can manage. So they are quite major surgeries, but they do help with quality of life if we optimize you, reduce your BMI or weight, make sure you don't stop smoking, and you try pelvic floors, and if things are not better, then the operations do help, and we can go around and doing them. So I'll quickly talk about bulk commit, because major operations, we can talk about them later, or you can ask me the questions and I'll try to answer. So bulk commit is an offered procedure. So we have a look. This is a camera which goes in with a little injection or needle which goes in, and it's just at the neck of the bladder level. So this is a local anesthetic injections we give on the side. Then we put a camera inside the urethra, just at the neck of the bladder level. There's a two-dimensional picture, unfortunately, but if you look at the hollow organ, hollow tube, four-dimensional, 1, 2, 3, 4, 4 sides. 1, 2, 3, 4, 4 sides. I give this injectable. The whole idea is to make that cushions, to reduce your chances of leaking and give that area a bit more support. Sometimes this the cushions do become flatter, and therefore sometimes we'll have to give a top up to get more optimal correction of the stress incontinence. And as I said, even with the cushions, sometimes it is not enough support and it doesn't work, and then we may have to give further treatment.
Thank you. So talking about specialist nurse assessment, so if you're referred here to Benenden with any of the things we're talking about, incontinence, prolapse, quite often your first appointment and assessment will be with one of the specialist nurses. So what we're going to do is we're going to take a history. We want to know a little bit about, what your symptoms are. Is it bladder related? Is it a prolapse? Have you had children, difficult deliveries? What is going on? We're always going to test your urine because we want to rule out urine infection or find out if you get recurrent infections. And then quite often we'll scan over your bladder, something called a residual scan, that will then tell us how well your bladder is emptying. Because if you've got some incomplete bladder emptying going on, that could be the cause of the symptoms. As I said earlier, we're going to look at your fluid intake. We're going to work on the bladder retraining. As I say, structure pelvic floor muscle exercises are the key, whether it's stress incontinence, whether it's overactive bladder. Bowel management, again, managing constipation. If you're overweight, we'll help you with, with weight loss, with dietary advice. And we'll also advise you about, exercises that you can do alongside sort of your pelvic floor. Pilates is very good for core strength, but you might want to avoid high impact exercises. Too much sort of squatting and weights might be aggravating your symptoms. Thank you, Abby. So while we're talking about an overactive bladder, we've said, 1.5 to 2 litres in a day. You don't need to be drinking loads. You might need an extra 500 mils of water if you're doing an exercise class, a lot of gardening, in the hot weather. Restrict your caffeine to 2 to 3 drinks during the day. And ideally, you should be emptying your bladder every 3 hours, and at night, not all once. It's really important, I think, looking at the colour of urine on the right-hand side of your screen. Not that you probably normally, look, but pay attention. If your urine is down the bottom end, it's quite orangey, it's quite yellow, it's suggesting that maybe you're a little bit dehydrated. That might be because you get a lot of urgency and frequency and you're trying to manage that by not drinking. But that sort of concentrated urine, that will irritate in your bladder, and it'll still make you need to go as much. You'll just be passing smaller volumes. You'll be more at risk of urine infections. Pelvic floor exercises. We thought this was an ideal opportunity to just talk about those. As you can see in the diagram, the green turquoise, is your pelvic floor. So your pelvic floor swings across, and it is like a hammock of muscle, swings from your pubic bone at the front across to the base of your spine. So imagine it as a really large muscle. It's not just something small, which is why it's so important. So to strengthen your pelvic floor muscles, we tend to do what we call fast contractions and what we call strong contractions. And to do a pelvic floor contraction, you gently squeeze at the back passage, so you feel you're trying to stop passing wind. And you also want to feel you then carry that squeeze forward to the front, so you feel you're squeezing to stop having a wee. But what you're trying to feel by doing both of those is like a lifting, a pulling up in the vagina. So fast contractions are where you would squeeze up for a count of 1, relax for a count of 1. up for a count of 1, relax for a count of 1. And we would normally advise doing 10 of those at least 3 times during the day. Very good for stress incontinence because it's working that muscle to snatch in quick with those sudden movements. The strong contractions more about building that strength and support. So you're going to need that if you've got prolapse to help to improve the support. If you've got urgency and you want to try and squeeze and hold on with your bladder, and we advise squeezing and holding that muscle, and you may only be able to hold for 3 or 4 seconds to start with. That's absolutely fine. Quite often we'll start at a hold for 5, relax for 5, and just do 5 of them and build that up as as that muscle strengthens. Really important when you're doing them, don't hold your breath, don't pull your tummy in. So if you stand in front of a full-length mirror, you squeeze your pelvic floor, you should still look exactly the same, but you should be feeling that lifting in the vagina. And it takes at least 3 months to strengthen up your pelvic floor. So when you start doing them, if you don't think they're working, don't give up. Really work at them and give them at least 3 months. So if we've done all of these things and actually you've still got bothersome symptoms, the stress incontinence, the overactive bladder, we can offer something called a urodynamics test. And it's basically a pressure test on your bladder. We'll get you to empty your bladder into a commode that measures urine, which will tell us what your normal flow's like. Again, we'll scan your bladder. And then by putting a little catheter into your bladder, we're going to fill your bladder up artificially. So your bladder's going to fill artificially. You'll have all the normal sensations, and you'll tell us when you get an urge to go. If you're leaking, we'll stand you up. If you normally leak with coughing and sneezing, we'll get you to cough. If it's with exercise, we'll do star jumps, bending down. And what we're looking at is your bladder muscle nice and steady all the way through the test, or is it giving little contractions, which is that overactivity? Or if in the test when you're coughing you leak, then that's sort of that diagnosis of stress incontinence. And all of that information is key then, for Mr. Gupta and the team to make sure we're giving you the right treatment.
Thanks, Jan. So as Jan said, for pelvic floor exercises, don't give up, because it takes 3 months to start showing a real good effect on you. Because when you go to gym and start, or if you have gone to gym or see anyone exercising, you don't build up any of your muscles by going to gym twice in a week. You build up your muscles when you have done it for at least 6 weeks to 3 months. Then you'll see the changes in your body. Pelvic floors are same. Easier said than done. But if you do it religiously and regularly, you'll get the results. Similarly, urodynamic test has got it's got 3 phases. One is 3 things to see. One is to show what is your bladder capacity. If your bladder is a very small capacity, your bladder is a big capacity, and if it's a small capacity, what is the issue? Is it the contraction, or is it just you're quite nervous, or what are the reason that you're not able to fill that properly? Second, whether you got overactive bladder, which is urgency, which we talked about, or you got stress incontinence, or you got mixture of both. And third, how well you empty the bladder. Do you leave the urine behind? How fast you empty the bladder, because that will determine whether we will A, teach you how to empty it properly, B, if we give any treatment to you, then how likelihood is you going to get a problem emptying your bladder in future once the treatment is done. Because when we're talking about bulkamid, we're talking about fascial sling, colpoid suspension surgeries, there are a level of obstruction on your bladder neck. So it will give us idea about how well you empty in the first place. So these are 3 main things which pick up with urodynamic test, which is physiological test of your bladder function. So we'll talk about some prolapse as well. And as we discussed about, the prolapse is a weakness in pelvic floor, which causes the bladder to come down. So if you imagine, so this picture, just to understand this picture, I'm really sorry we don't have the pointer today, so otherwise I would have pointed where you should see. But if you see this picture, it's a 2-dimensional picture. So we're looking at women from front to back. First thing you notice, behind that little ovoid thing is your pubic bone. So behind that, the first hollow organ you see is bladder, and a tube which drains water out, which is called urethra. Behind that is the vagina, and the top of that is the womb, neck of the womb, and behind that is the back back passage. So that's the human anatomy. Bladder, vagina, back passage, and on top of that is the womb. So that's what you're looking at. Now, if you see the vaginal area is a hollow organ, and that itself is anatomically a hollow organ where the hernia of the organs can take place if your supporting tissue in front, back, or the middle has failed. So there are three compartments in the vagina: front where the bladder is resting on the vagina, top where the womb is located, or where if you had a hysterectomy, it's the top of the vagina, and the back wall where the bowel is resting. So there are three compartments: front, middle, and the back. So that's your anatomy. So any prolapse is basically a hernia of your organ through the vagina. And because vagina is a hollow organ, it becomes susceptible for herniation to take place. So that's what prolapse means. The prolapse, again, in urogynecology, everything is about quality of life. And the only preventive strategy is pelvic floor exercises, bladder retraining, not lifting heavy weights, not getting constipated, life adjustment like smoking cessation, improvement of BMI. Those are the only preventive strategies you have. We never do a prolapse surgery just because it may get worse in future. Because A, prolapses may not get worse in future. B, there is no guarantee of operation and the prolapse will not come back. So it's all about quality of life. If the prolapse is affecting quality of life now, we do the treatment. Prevention is in your hands, not in surgical hands. So that's where the preventive strategies come in. So what causes prolapse? So anything which can weaken your pelvic floor, which can cause. So repeated straining. So if you're constipated and you keep straining, it's not going good for pelvic floor. If you keep lifting heavy weights, not good for pelvic floor. Chronic cough, not good. Menopause, as I was saying, that women's body do go through a lot of trauma after menopause, and the tissues do become weak. Childbirth, another trauma. Previous surgeries in pelvis area. Unfortunately, as we all go older, our tissues go weaker, and unfortunately, we do all go older. Hysterectomy can predispose you for, and this we're talking about hysterectomy done for heavy periods or fibroids or that reasons rather than for prolapses. Because once you do the hysterectomy for prolapse, the supporting organs have already failed. So these are when you don't have prolapse and you had a hysterectomy, then hysterectomy can also increase your chance of prolapse coming. And then obesity, we have talked about obesity quite a bit. So again, this is a good picture to describe your own anatomy, because sometimes this is where it is. So you've now known bladder, urethra, that's what I was talking about, from front to back, vagina, uterus, back passage, and the anus. So what is cystocele? Cystocele is a prolapse of your bladder through the vagina. So if you look into the front compartment of the bladder, in this particular picture, you can see the bladder now herniating into vaginal canal, and that's called cystocele. Yeah. Now, in this compartment, you can see the back wall bulging in, which is called rectocele. So while we are in these pictures, I'll just briefly talk about how these patients usually present to us. So the cystocele, which is the bladder prolapse in the front wall, can present to us with a bulge. All the prolapses can present bulge, uncomfortable feeling. Usually, the prolapse get worse later on the day. So when you're on your feet for a long time, you will feel that your prolapse is getting worse. If you feel that you're lying down and you're feeling a lot of discomfort in the vaginal area and the pain and all that, probably that's not the prolapse. There's something else going on, because typically prolapse symptoms get better when you're lying down. It's purely the gravity. If you're on your feet for a long time, it gets worse. So bulge can happen with both cystocele, rectocele. Discomfort can happen with both cystocele, rectocele. And the cystocele can present if you're not emptying the bladder that well, or you have typically what is called post-micturition dribble. So you feel you have emptied, you get up, and you feel that you need to empty more. So that's can happen with cystocele. Similarly with rectocele, because if you can see, there's a little pouch created for where the arrow is, where your rectocele is going or the prolapse is going. So when you're emptying the bowel, it creates a little pouch, and you can see your bulge getting worse when you're trying to empty your bowel. And then sometimes you may have to gently digitate or hold your perineum, or sometimes in a crude way, you may have to push through the vagina to get that in place to empty the bowel better. So these are the common symptoms patients present with. And this is where the womb has coming down. So that's called uterine prolapse. So this is now middle compartment has come down, which is womb prolapse, but you can see it's also dragging the front wall and the back wall. And this is the prolapse of the middle compartment. Not often we see one compartment prolapse. Sometimes we see this double compartment prolapse, and sometimes you see all the three compartments. Not unusual, because the pelvic floor is the pelvic floor. And how it will affect your which compartment is difficult to say. But sometimes you get one compartment, two compartment, and sometimes all three compartments. Not unusual to get three compartment prolapse. And then sometimes when you have a hysterectomy, the top of the vagina, which is labeled as the vaginal cuff, that can come down, and that's called vault prolapse. So now we'll talk about the treatment of pelvic organ prolapse. But the aim of any prolapse treatment, again, I'm going back to the same thing, is quality of life. So one is to make you feel better. So if it's dragging sensation you're getting, the bulge you're getting, you're not emptying the bladder well, not emptying the bowel well, to get your symptoms better, to get your quality of life better. That's the aim of prolapse surgery. And sometimes to restore the function. So if you're not able to have sexual intercourse because everything is hanging down, or you're not able to put a tampon in the vagina because it is obstructing, then to restore the function. So there are two things. One is to improve your quality of life by your physical symptoms, and second, the functions of the vaginal canal. And that's the two main principle of any prolapse treatment. And I'll talk to I would hand over to Jan if she wants to talk a bit about pessary and pelvic floor exercises. That's right.
Yeah, absolutely. So yeah, I think pelvic floor exercises, we've talked about that. Hormone treatment. So vaginal estrogen can actually be a bit of a game changer, I think. And that can either be a little pessary, something like Vagifem pessaries, or a cream, estriol cream, very low dose of estrogen. I think people worry, particularly if they've not had HRT, they worry about having estrogen. It's an incredibly, incredibly low dose of estrogen because you're putting it exactly where it needs to go. You generally use it every day for 2 weeks and then just twice weekly. But if those vaginal tissues are prolapsing, it's suggesting they're thin because they're losing estrogen. So along with the pelvic floor, it's all going to plump those tissues up, give more support. And sometimes that may be all the treatment that you need.
And sometimes the patient, when they have discomfort, dragging sensation, then you may get, there's a condition called vulvovaginal atrophy, which is lack of estrogen in the vaginal area. And it really helps. And even if you want to do any pessary or a surgical treatment, it is so important to build up those skin. Mm-hmm. It's a low dose estrogen, it's vaginal, so amount which comes in your bloodstream is minimal. So when we recommend, then it is very safe. The only time you have to be careful is if you had any history of breast cancer, and not family history of breast cancer. If you had a breast cancer, and that too, it depends on how long ago you had a breast cancer. So if you had a long time ago, we can also always give it a cautious estrogen, and you can give it for short duration. That really helps. Then vaginal pessaries, there are various types of pessaries. Ring, that is ring with support, that are also called shelf. The whole idea is goes in the vagina and it supports. It's again not preventative of prolapse getting worse. It is only to support that area. It needs to be changed every 4 to 6 months, or at least now we got new pessaries, which are silicone pessaries, which can last for a longer time. So what we need to see in 6 months' time to take it out, make sure it's not forming ulcers in the vagina. It's still the same size is good for you, and then wash it and reinsert. The pessaries work only in 50% of the patients, so it only works in 1 in 2 patients. The primary reason it doesn't work, sometimes the vaginal shape is not suitable for a pessary device. Sometimes your muscles are not strong enough to hold it in place, and sometimes you get a lot of vaginal discharge. So it's a discontinuation, or it presses on bladder and you start leaking. So, but therefore, it doesn't work in everyone. It works in 50% of patients, and it needs to be changed or at least looked at in every 6 months. If you're sexually active, then usually only the ring pessaries or the ring pessaries with support can help. Other pessaries don't work very well because we have to teach you how to take the pessary out and reinsert yourself. So we'll have to empower you to do it. Other pessaries are very difficult for you to manage it yourself, and then you need a specialist, people like us, to help. But this pessaries, you can have sexual intercourse as long as we explain you how to, and also train you how you can help to remove the pessaries and reinsert yourself. And the last option is surgical options. So surgical options are, again, as I said, is either to make you better, so to get the anatomical correction and improve the functionality. So for a womb prolapse, when the womb is coming down, so in this particular picture, the womb is already out, and it's showing where the stitches can be. So if the womb is coming down, then the operation vaginal hysterectomy is an option, and there are alternatives to vaginal hysterectomy, which is one is called sacrospinous fixation, where we stitch the neck of the womb with a strong ligament called sacrospinous ligament, or something called a sacrohistopexy, which is use of a mesh, which is done through the tummy. In Benetton, we don't offer mesh operations. And for prolapse of cystocele, which is front wall prolapse or back wall prolapse, you do a repair, which is where we open the front wall, push the bladder back in, bring your tissues together, suture it up, do the same on the back of the vagina. Hospital stay is usually 1 night. Complete recovery will take 6 to 8 weeks, depending on how many compartment prolapse surgeries you had. Risk bleeding infection, which can happen with any surgery, because we operate so near to bowel, bladder, tube draining created bladder called ureter. There's a very small risk, less than 1% risk of injury. If anything happens, then we do a keyhole surgery cut in the tummy to correct this up. Prolapses can come back. So make sure you don't lift heavy weights, don't get constipation, because prolapses can come back. And as I was saying to you, that BSUG, which is British Society of Urogynecology, if you go into BSUG website and go into patient information leaflets, you will have tremendous resource to read through, and all the nice guidelines and all that are there. So and there are a lot of patient decision aids and patient leaflets. So these are leaflets which are being written and made for patients in the mind. So it's written for you as a patient, so that you understand it better. So if you want to go and have some resources to read, I would recommend that you go to British Society of Urogynecology website, go into patient leaflets, and then you'll open, and there will be a lot of resources for you to read, and they will have a lot of informative information there for you to access. I think we are ready for a question.
Yes, lovely. Thank you, Mr. Gupta. Thank you for joining us and sending in some questions. One question is, at an initial assessment, are you able to diagnose a prolapse just by a physical examination, or would I need any further tests?
So it really depends on your symptoms and your findings. So if your symptoms are predominantly prolapse related, we usually can diagnose in the first initial assessment and examination. There are rare things, not rare, but there are few occasions when it's difficult to assess during the first consultation. If you are using the pessaries yourself, and if you're on ring pessary or anything, and you want to have surgical correction of prolapse, and you've been using pessaries for quite some time, when the pessary comes out, your prolapse doesn't straight away come down. It takes some time for prolapse to come down. Therefore, we may not be able to diagnose that well, and we may have to examine you without pessary after 2 or 3 weeks. Second, if your prolapse gets worse towards the end of the day, and your appointment is first thing in the morning, and sometimes we don't find that kind of prolapse, and then we may have to examine you in standing position or the Sims position to find out, or sometimes we may have to give you another appointment for us to come and assess your pelvic floor again. However, majority of cases we can diagnose the prolapse and give you the treatment plan even in the first visit, majority of times.
Lovely, thank you. Sorry, I'm just going back up to an earlier question. If you're in your 80s with urinary incontinence, is it something that you have to put up with as part of the aging process? No, no would be my answer.
No. The answer will be no. Yeah, you shouldn't be putting up with it, because at the end of the day, it's about quality of life. And at the end of the day, frankly, age is a number. If what it prevents you doing, that's the most important thing. And you may be the most fit 80 years old who goes to gym and leaking and you need treatment. And just because you got 80 years old should not stop you seeking help, an assessment of what we can offer and what we can't offer, and have a very realistic and professional discussion with the healthcare professional. But putting up with a leak, I wouldn't say is the right thing if it's affecting quality of life professionally.
Definitely. It may just be, as I say, assessing pelvic floor. You talked about the bulkamid, the bulking agents can often be, a good starting point. A lady who's got prolapse wants to know if it's fine to have a pessary even though she's had lumbar surgery.
So if you have a lumbar surgery, you can definitely have, or you got spinal surgery, you can definitely have the pessary. But obviously, if the prolapse is affecting you, and I can see from your description, it affects you when you go to the gym and you had the operation on your back. Pessary can help, and we can definitely try to put it in. However, as I said, not all prolapses are suitable for a pessary device, because sometimes you had a previous surgery. It really depends on if you have any pelvic floor to hold it. And if you have a very low rectocele, just at the opening, your muscles are not strong enough to keep the pessaries in properly. So it will depend on the assessment, but of course it can be tried. But we have to individualize the care depending on how fit it will be for you. But we can have that assessment and certainly try it.
Thank you. And a question, are the equipment advertised for pelvic floor any good, and do they work? I'm not a great fan of the gadgets that you can buy. I think the important thing is you doing your pelvic floor exercises and knowing that you're doing them properly. I think if the pelvic floor is not overly strong, there may be a place for some of the machines that give a little bit of electrical stimulation, but I think sometimes they need to be used with caution. And I don't think they're a quick fix. It's you doing your exercises that's going to help. Do you agree with that, Mr. Gupta?
Yeah, I think so.
Yeah, and there's also a question about getting an appointment with the Continence Care team. So you can do that by contacting the private patient advisors, and you can book a direct appointment with any of the specialist nurses. And we'd love to see you and assess you and help you with your symptoms. A question about, is Ovestin cream good for your pelvic floor if you've got urgency?
Yeah, so if you're into your menopause, and it will be good to see someone, specialist, or even your GP should be able to assess whether there is something called vulvovaginal atrophy, which is lack of hormones in the vaginal area. And if you're menopausal and you get sense of urgency, sometimes you may not have overactive bladder, but you do get slight inflammation because of lack of hormones in the vaginal area. And what I was describing as vulvovaginal atrophy can cause urgency. So once you have an assessment, I think Ovestin cream will be very sensible to start once the assessment has been done. And this assessment can be done by your general practitioner or a specialist nurse at your practice as well, just for starting the Ovestin cream.
Definitely. And somebody's made just an observation really that they're waiting to be seen by a gynaecologist, and obviously the wait in the NHS is a long time. There's information there on the screen, and there's a discounted price for listening to this webinar. So if you wanted to come along to see Mr. Gupta or one of the team, we'd be able to assess you and help you. Lovely. And just a question actually about using vaginal, the pessaries, the support pessaries. Is it safe to have one for the long term?
Yeah,
to use long term?
there is no issue with using the long-term pessaries as long as this is reviewed every 6 monthly. So as we said, we need to make sure that this is still fit for you. Does it pessary needs to be changed, or it can be washed and reinserted? And is this pessary giving any ulcers or any trauma to the vaginal tissues? That needs to be assessed every 6 monthly. As long as that's getting assessed and you're happy with it, it can be used for long term without a problem.
Lovely. Thank you, Mr. Gupta. So thank you again for your questions, and I'm really sorry if we haven't managed to answer those, and we will try and answer and reply to you. If you provided your name, we can then follow that up also with an email. Is this our final slide? There we go. So as a thank you for attending this webinar today, on the screen you'll see that we're offering a 50% off the value of your consultation. You will get a call back from your dedicated private patient advisor and an email. So it'll have a recording of this session if you've maybe missed what the medications were, something else that we were recommending. And that will also give you information about treatments and the loyalty reward points. And it will also update you on future events and webinars. We'd really like it if you could please complete the short survey to help us improve and tailor future webinars to your needs. If you feel you'd like to book a consultation, there's somebody available on our private patient team tonight until 8 o'clock, or between 8 and 6, Monday to Friday. And that number is on the screen, 01580 363 155. We have several more webinars coming up, including plastic surgery, ear, nose and throat, and cataracts. So please sign up for these if you're interested. Finally, I'd like to thank Mr. Gupta for a very informative presentation, and thank you for joining us tonight. We hope to hear from you soon. Thank you very much again, and goodbye.
Thank you.
Thank you.